This is the Discussions in Body Art podcast, where stakeholders in body art can hear concise information that's useful for body art safety and regulatory related topics. I welcome you. My name's John Johnson and I'm your host. Please see Session 0 for disclaimers. I have surveys for you at newflowerstudio.com. Whether you're a body artist, facility owner, or regulator, your anonymous input is valuable. Hi everyone, thanks for joining me. Don't forget, most of my content is on Patreon, so if you're not a subscriber there, you're missing a lot of stuff. I upload content to these free platforms at a much slower rate. This session is a really long one, and like other kinda long sessions, will end partway through for you because you're listening on a free platform. In this session, I'm going to discuss the differences I see in body art compared to healthcare, surgery in particular. I, like everyone else, go to the doctor, have small procedures performed, some more invasive than others, and I've had one outpatient surgery in recent years. This is in addition to 2 or 3 dental visits a year and 1 emergency room visit in 2024. I tell you this because, like a lot of my colleagues, I'm pretty observant. When I'm in a healthcare environment with sharps containers, I pay attention to how sharps like syringes are handled and where the containers are kept. I pay attention to how gloves are donned, doffed, and when they're changed. I see how pre-sterilized instruments are stored and opened, how barriers are placed and used or not used. I notice what disinfectants and antiseptic products are used and how they're used, or not. The most experienced body art practitioners have a critical eye for cross-contamination. We can leave nearly any medical procedure with a checklist of things healthcare workers touched without gloves on and how many sterilization pouches they mishandled. We notice when the sharps container is mounted on the wall where it could unfortunately serve as a headrest for patients or be a paperweight on a doctor's desk. I had a legitimate medical procedure done recently, and the doctor came into the room with 2 sodas and a box of apple juice for himself and his assistants. He placed them right on a shelf in his clean work and storage area with drawers, sundry jars, and sterile products. I'm not suggesting this is allowed by whatever regulations or codes he's bound by, but if this was a tattoo or piercing station, this would be a violation according to my health code for body art where I live and work. I don't say any of this to condemn healthcare workers, not at all, I promise. It's common for body artists, I think piercers more than tattooers, to transition into healthcare when they're no longer interested in being a body art professional. I know former piercers who I've personally worked with and have even worked at my studio become a radiologist, surgical tech, ER nurse, paramedic, and at least a couple became sterile processing technicians. This list is just from my experience. A lot of my current body art colleagues could say very much the same thing. I can call these people anytime, and regularly do, to ask for their perspective, comparing their body piercing experience to their healthcare environment. There's a lot to learn from these relationships. Healthcare, especially surgery, is often used as reference and source of guidance for body art information. My position is firm that in the medical field, risk management is tailored to a known risk itself, the level of actual hazard that's present. Policies and technologies are in place according to available data and technology. Body art is a little different. We don't have industry-specific research available for the unique risks body art practitioners must manage. As a consequence, a lot of us want to take guidance from healthcare-specific organizations and rigidly apply that information to body art without consideration for its intent or spirit, specifically when it's surgical-themed information. It requires real critical thinking skill to read and study guidelines from medical-specific organizations and draw from them information that's actually practical and realistic for body art. The danger, in my opinion, is being overzealous and taking medical guidance out of context, intended for much higher risk procedures and environments, and pretending it automatically applies unilaterally to body art. Do that often enough and you might just convince yourself that body art is inherently life-threatening. In fact, I've had someone tell me they know people die because of piercings, and the only reason the rest of us don't know is because piercing complications aren't considered during autopsies. I've also been told by a piercer that piercers should have the same education and certifications as surgeons, even though that same piercer didn't have those same credentials, meaning they gave themselves an exemption while essentially wanting others to endure professional hardship. That's kind of the inspiration for this session. A lot of times, people in body art who want to create the most strict parallels to surgery already meet the standards they've created in their heads for everyone else. It's a very privileged position to have the resources that others don't and pretend you're working to the level of a surgeon, and that this is necessary to save lives. I'll repeat what I said in the session titled Perspective, that there are far more body art services than surgeries performed every day, and more people receive healthcare-acquired infections or die from surgery than body art. It's not even comparable. So maybe surgeons should figure out why the body art survival rate is so much higher and replace their surgical practices with body art practices. Or maybe body artists can figure out that the genuine risks from body art aren't really comparable to surgery, and like surgeons, our standards should be relative to our risks. I've spent the last year or so creating a list of the following differences between body art environments and procedures and their healthcare counterparts. Once I finish, it's quite possible you'll agree with me that body art is unique, and studying surgical information requires a lot of discernment between what's applicable and what's not. There's about 60 bullet points here, so this will be considerably longer than my other sessions, so thanks for your patience. Also, they're not in any order of importance at all. They're just notes I made during my own experiences, including visiting medical facilities, sterile processing departments, and interviewing my own friends about these topics. Here we go. The paperwork for medical procedures, outpatient surgeries, may be signed weeks or months in advance and may require no additional signing on the day of the procedure. Simple procedures may have no paperwork at all. Next time you visit your dentist or doctor, pay attention to this. Not long ago, I had a mole removed. Antiseptic, anesthetic, and a scalpel. Done in a room no different from a piercing room. I went straight from the elevator to the procedure room after checking in, received an anesthetic by injection, and was on my way back to my car in about 5 minutes. I've had a couple surgeries and had to complete health directives in case I died. Artists train artists through apprenticeships with little oversight in the United States. Very few departments have any requirements for apprentice training standards in their health codes, and there aren't accredited schools licensed for body art. Vendor reps from device manufacturers attend a lot of surgeries, literally in the OR, to make sure the surgeon uses the device properly. That's how complex many medical devices are. No tattoo machine manufacturer sends reps into tattoo facilities to look over the shoulder of an artist and micromanage the session. Anesthesiologists, nurses, surgical techs, and assistants are also present during surgical procedures. What body art procedure requires all that? Surgical hand washing stations aren't in the operating room, they're outside the room. Your dentist and local clinic probably has a hand washing station in their procedure rooms, but not surgeons. I've said before that our body art environments are more closely related to dental and walk-in clinic environments. UV light is sometimes used for disinfection of environmental surfaces in the OR. My studio has a small UV light in the showroom, since that's where the highest amount of foot traffic exists and the largest number of high-touch surfaces are. But not too many body art studios use these anymore. UV light comes in 3 types, UVA, UVB, and UVC, with UVA being the least lethal to microbes and UVC being the most effective. Some of them result in ozone being created, which adds to the risk of them being used. People should not be in a room when a UV lamp is being used, especially if there's ozone. Sterile long-sleeve gowns are worn during many surgeries. I don't see any body artists wearing them though. The risk simply isn't that high. This is where this session ends, but the full session is on Patreon. There's free blog content there too, so if you're interested in hearing or reading more on topics like this, go to patreon.com/xdredjohnx and check it out.